So I'd just like to welcome everyone to the third in our series, which is focusing on Genomics England. We're very fortunate to have Leigh Jackson, who's a lecturer in genomic medicine at the University of Exeter. Leigh is someone who has experience both in the lab, but also and in clinical genetics, and has also had, sorry, I'm just going to turn off my email, has also done social science research. So it's of great benefit to us to actually come and have him speak as part of this series. And thank you, Leigh, for agreeing to do that. And so he's going to talk about some of the research that he has done around Genomics England. And so I'm going to hand over to you, Leigh, and thank you very much for coming and presenting.
No, thank you very much for the invitation, Jane. It's really an honour to be here. As Jane says, I'm a lecturer in genomic medicine at Exeter, and today I'm actually also a student in genomic medicine at Exeter. I'm taking the bioinformatics module and swamping myself in sequence analysis. So this is going to be a nice interlude to that onslaught today. So I'm going to talk a little bit about kind of my time with the Southwest Genomics Medicine Centre, and hopefully I'm going to pick up on some of the issues that were raised by Mike Parker in his kind of organisation level talk on the 100,000 Genome Project, and look at more some of the practical issues that our guys have been experiencing and what we're trying to do to get some evidence, some empirical evidence on how we can make those things better. So I won't go into too much background about the project itself, because it's obviously the third in the series, so I imagine most people are aware of the project. But I just did want to pick up on the infrastructure, and this being the 13 different NHS genomic medicine centres serving large populations, leading to a further 70 hospitals within those centres. And these are mapped to the academic health science network regions. The reason I think this is important, because already we split this into 13 different locations. Each of those have kind of the autonomy to run the project locally as they see fit within certain boundaries, of course, but it does mean that there is kind of divergence in practice. So when I'm speaking only about what's happening in the Southwest, and that might not be representative of everywhere else, so that's just kind of a bit of a caveat there. I also just wanted to highlight kind of the key functions of the GMCs, and I'm not going to talk through all of these, but just to point out that there's a lot of different responsibilities that the genomic medicine centres have to do to make the project work, and kind of by and large, certainly in the Southwest, this is done by a very small core team. So there's a lot of kind of ball juggling to be done, I guess, is the point that I wanted to make there. So in the Southwest, the GMC that I was a part of has 7 hospitals, serves a population of 2.2 million, also happens to be probably the most elderly population in the country. Lots of people like to come down to Devon to retire, so there are interesting variations in some of the conditions that get seen down here. And as of yesterday, there's been 870 individuals recruited to the rare disease arm of the programme, 379 families, and 105 patients with cancer. And as you can see from the pin map, we're recruiting all over the Southwest Peninsula, which is quite a large area. So that's I think background kind of dealt with. I did put in a slide about how I think the project works and how it looks to me from the bottom up. I'd completely forgotten that I'd animated this slide, so I will nip through the animations so we can populate everything quickly, because the point I wanted to make really is about this bit here. So the way I see it as part of the project, I was employed by an NHS Genomic Medicine Centre. I was an NHS member of staff. I was working with other NHS members of staff and NHS patients. And when we had our review meetings, it was with NHS England. And so I guess the point I'm making is very much kind of on a day-to-day basis an NHS project with NHS staff and patients. The reason I say that is because I think Genomics England are kind of over here a little bit. and it's more at the kind of the upper level when it's talking about the ethics advisory board, which Mike spoke about, data access, and then the interactions with the Gene Consortium. And then we've got Health Education England on the other side doing the genomics education program, which was kind of my role as the education and training lead. The reason I point this out because while I was working and since I've been working as part of the project, kind of, I guess the most common question I've had is people said, what's it like to work with Genomics England or for Genomics England? And kind of the point I want to make is I don't know really. Actually, in reality, it's an NHS project with NHS staff and NHS patients. And whilst I've met people from Genomics England, of course, it doesn't feel like that on a day-to-day basis. And I think that that's something that's translated across to the patients in that kind of, in our experience, when people talk about the kind of the blurring between research and the clinic and the issues that that might bring, kind of actually in our experience, the patients see this very much as an NHS project, that this is part of their care. They realize that they have to do things a bit different with consent, but it feels part of the NHS. What I think is interesting, or what I found interesting, is actually the people that I think have more of an issue with this research and clinical boundary are the clinicians. And actually, in our experience, the clinicians, despite the messages that get passed out quite regularly, the clinicians still very much see this as a research project. This is a research project. It's not part of standard NHS care or standard NHS offer. What that means is there's a bit of a disconnect between what the patients think they're a part of and what the clinicians think the patients are a part of. And also we get feedback like the clinicians don't have time for the research. There are other competing studies. They don't know who they should prioritize. But then on the flip side, we have research nurses that can't use any of their time because it's not an NIHR portfolioed research study. Pathology labs don't have enough space to cut up the cancer samples. We have comments like entering phenotype data about the patients isn't the clinician's job. They're just recruiting patients to project. And kind of all of those things would not tend to be fed back if this was perceived as a fully NHS integrated project. And it's been summed up quite well when the messages kind of we were fed down to talk to the clinicians about is that whenever they submit a request for an MRI or a PET scan, there might be lots of clinical data they have to input. They would never come back and say, well, I haven't got time for a scan, I haven't got time for an MRI. So it's trying to kind of think about getting the message across that this at the moment is to the end user, to the trust. This is a free clinical test that's being given that certainly for the rare disease patients could have a 25-30% diagnostic pickup rate. And so, yeah, there is still a bit of a disconnect about the identity of the project and what it is. I think this has led to picking up on some things that some of the questions that came up during Mike's talk. This idea that this project is not uniformly available to patients. Locally we still have 50% of our referrals from clinical genetics. Whilst there are quite a few clinicians that have referred to the project, most of them only recruit 1 or 2 families. So there's, it's usually 1 or 2 clinicians in the department that are kind of actively involved in this. And so there's kind of issues around the equity of access to the project and to this quite powerful resource. Okay. So one of the things that locally we're doing to counteract that is our network of genomics champions. So we're sending specialist registrars out into the specialties to kind of shout about genomics in the first instance, but also make the point that this should be something that everyone's doing routinely, and it shouldn't be down to one person or one nurse or one referring clinician, and it's got to become far more integrated than that if it's ever going to be mainstreamed properly. So I'm going to pick up on just a couple of issues. There are lots that we could have talked about. So one of the first ones I'll quickly mention is the idea of consent for the cancer arm of the project. So a lot of what we're getting fed back by our recruiting nurses is, they really don't think that before surgery is the right time to consent patients for this. patients have more pressing issues to consider, like their recent cancer diagnosis, their upcoming surgery. The personal clinical utility is far less likely on this arm of the project. The turnaround times for the sequencing, the sorts of information we're expecting is very unlikely to help people in the cancer arm of the project. This is far more the researchy side of things. So the imperative there, the time kind of constraint, is more about preserving the tissues than it is about the need for the patient to join the project quickly. So one of the things that we've done to try and tackle that locally is before surgery, the reason to get consent before surgery is because you need some of the tissue samples and the blood samples before there's been any treatment or before surgery. So we're doing things like using a tissue bank consent. So it's a very kind of broad consent to our local established tissue bank, and then going back to people when they've got more time to think about things after and having the longer consent conversation about the project specifically, to then give them the opportunity to join there. That's been found very useful. For some people, it is logistically challenging. Everything is set up in the kind of pipeline to work as this front-loaded consent model. So things would have to change there if that's going to become the norm. But certainly our recruiters feel that might be more beneficial to the patients. I just showed this quote up about informed consent because I think it's appropriate here. This is from some previous research that I've done with around genomic testing and genome-wide procedures. And I won't go through the quote, but the take-home part is that in 3 instances, the participant refers to informed consent as a joke, and it's impossible. And we still insist on it. And this was in the context of surgery, so it's very clear from that this person was a surgeon, and they don't believe their patients really take anything away from the consent at all times, and so therefore extrapolating it to be fairly impossible for a genome-wide test. What might not be clear from that quote is that this participant was a member of NHS Research Ethics Committee. And this just kind of highlights this kind of issues that we're facing with people being very confused about this idea of informed consent for genome-wide tests. And there are lots of reasons for saying that actually there are huge challenges in getting kind of what we traditionally would consider an fully informed consent for these kind of tests. So it's something to bear in mind. Another kind of initiative in the Southwest to try and help with that is the launch of the National Information Helpline. So it was launched in November by our Genomic Medicine Centre. And the idea was to answer people's questions about the project and also facilitate what's kind of called a structured consent conversation, where they get referred on the phone to trained recruitment nurses who will take them through the process. And it's not telephone consent, they still need to go for their face-to-face consent appointment. But the idea being that this could not just be a one-shot opportunity, that people could have more time to think about these things at a time that's more convenient for them, have some of their questions answered in advance, so that when they go in, actually that might reduce the time in that consent appointment and therefore increase the capacity to consent, but also give them a bit more flexibility in time to consider things at their leisure. And hopefully soon we'll start getting a feel for the effect that has had. We have had a large number of calls, so it is being used, so it'll be very interesting to see if that translates actually into a reduction in the average consent appointment times or not. Cancer sample size is another project that's been looked at locally, and this has sprung out of the concern that there are quite large tumour size requirements for the project. This means that actually a lot of patients that would otherwise be eligible are not, just because of the size of their tumour, and also kind of the worst scenario of patients being consented pre-surgery and then actually there not being enough tissue and them not entering the study afterwards. And given that it's quite a significant consent process to go through and think about all the different issues involved, to then not actually become part of the study is very disappointing for the patients, obviously. And our local data from our lab show that actually the amount of data we're obtaining from this amount of tissue is orders of magnitude higher than what's needed for the sequencing, and is a very high quality. And so now one of our project students is looking at comparing this across all the different genomic medicine centres in case there's any kind of bias because of the types of cancer that we've had, or any other variables, to see if actually that's something that we can do as a tangible, practical solution to improve the kind of access to this project for more people. One of the other projects which I think could have some real benefits is the issues around the consent appointments for pediatric patients and the sample taking. And this has been fed back from all our child nurses, really, that some of these children with learning difficulties are very difficult to take blood from. And certainly when you're trying to have a consent conversation with the child there and then take samples, this can turn into an extremely long and extremely difficult and kind of a very stressful time for the parents and the children. But the majority of these children are kind of in the rare disease pathway we're talking about here are due to have regular blood samples for routine care anyway. And so we're looking at ways to kind of join up the different communications so that actually, rather than it being a specific separate appointment, this can be tied into routine care for the blood, and to separate out the consent taking and the sample taking, so that maybe the consent conversation can be had with the parents and the child doesn't need to be there, and so that might make it easier for them to feel that they can kind of discuss in more time, more detail, the actual implications of what they're agreeing to. But also that there's information about a lot of these patients being very needle phobic, and at the moment that's not kind of getting translated through the system. So the nurses that are responsible for taking consent and the samples don't have information about the patients early enough to kind of triage them into their individual needs. So we're looking at ways to kind of shorten that pathway and increase that communication. One other interesting thing that came out of that is that this observation that parents aren't always expecting to give blood samples themselves. And that's in all of the information booklets, it's in the consent documents, but it's an indication, which is probably not a surprise to all of us here, that actually patients don't always read all the information or the consent documents. And so we're looking at ways of kind of prompting that during the appointment making phone call to say, that you're coming in for your consent conversation and sample taken, and if you consent, we'd be looking to take a sample from you and your child, just to kind of give another reinforcement, because it has apparently been quite a shock on the day to parents to suddenly learn that they're giving samples too, as this is something that they hadn't really thought about. I'll finish on a couple of things about additional, incidental, secondary findings, whatever your chosen word is for them. And I'll credit Gil Crawford here for this picture. I saw her use it in one of her talks, and it's kind of stuck with me as a great explanation of what we're talking about here. Rather than putting up lots of different definitions, it kind of captures it. So just as a quick summary of some of the previous work that I've done on incidental findings, which is kind of where this is my area of interest, I found within the NHS that there are very case-specific and lab-specific decisions being made about whether to feed this sort of information back. We found that there's kind of no real consensus of public opinion, as many others have. But certainly in our work with the REC members, so the Research Ethics Committee members, they felt quite strongly that researchers are not obliged, nor should they attempt to seek out incidental findings. And also they went further to say that they might overrule a participant's consent if the incidental findings had serious health implications. Now I mention this here because this is kind of, these 2 points are quite at odds with the approach of Genomics England and the 100,000 Genomes Project. They are taking an approach where they are seeking out these additional findings. Obviously they cease to be incidental when they're being sought for. And that goes against kind of the feelings of the Research Ethics Committee members. But I think there's an important difference here in that work was in research, and this is clinical, well, more clinical than pure research. And I think there is a difference there. And the kind of take-home message from all of my previous work is that everyone was kind of seeking a bit of guidance and information, and in coming up with this strategy of feeding back this list of conditions, that is certainly guidance. And so from the one aspect, that is welcome that at least a strategy has been put there from the start, and that's the way it's going to be dealt with. I mean, I think it still is in danger of causing some confusion in that it doesn't really actually address genuine incidental findings. I mean, they're not going to be fed back, but I think there could be a bit of a disconnect between what the public think is happening and the feedback we've had from some of the patients is that they kind of think that they're getting a free health check, you know, that those are a list of all the conditions they might be interested in, and therefore if they don't get anything back from there, they've got nothing to worry about in life. And you know, I think that is a serious concern. What we've also found from our local data is that very few of our participants decline these additional findings. And it's usually a family decision when they do or when they don't. It's extremely rare for there to be differences of opinion within families. You know, we can speculate a lot about what that says about how much people are thinking about these things. But one of the other things that I think our recruiters feel strongly about is that for something that is expected to come up in a very small minority of people, these kinds of discussions take up a larger than proportionate amount of the consent conversation. And you know, as Mike very aptly put, explaining the primary findings to people is going to be difficult enough and complicated enough. And I think there's a danger that we're kind of spending too much time focusing on the kind of the secondary and additional findings and the kind of the carrier state of things at the expense of working a bit harder on kind of understanding the primary reasons for the patients being part of the study. So we're looking to explore the motivations of our local participants, because we think actually there probably is going to be some regional differences here. I know lots of other groups are doing this on a national level, and looking at why they accept or decline the additional findings. And also kind of something that is an interest of mine is that I'd like to have a look at the evidence base for this list of genes for the variants that are being fed back. And I'm thinking there about ascertainment bias, where we know a lot of our existing data is based on like high family history of these conditions, and we're far less sure of the evidence, I believe, in a kind of a population-wide setting. And you know, people are either going to take these findings or not on the basis that these are the most important ones for which there is a treatment or some kind of course of action available to them, leading to the kind of expectation then that they might feel upon them that if there's something is found that they should do something about that. And this may all be based on risk values and penetrance values that actually we're not sure of in a population setting with no family history. And so then I would, you know, the kind of extension of that is to go back to participants, whether it's in this or any other kind of genome-wide study, and kind of explore whether their choices would be different about this information if penetrance values are significantly lower. So if, you know, if there's a 60 to 80% chance of their BRCA variant causing breast cancer, that's one thing. If it's 20% or getting close to 15%, and there's a 12.5% lifetime risk anyway, you know, you'd imagine that that might significantly change people's opinion on the value that they put in this information. So I think I will stop there, and that's about 20 minutes. And you know, that's kind of a group of all the various people that are involved in the project, and that's growing by the day, that slide. So I'll just point out kind of Steve, who's the project manager, obviously Sian's the program lead, and Anna's the deputy program manager, that kind of do all of the day-to-day work in holding this project together. And yeah, I'm happy to hang around and take any questions that I can answer.
Can people hear me?
Yes, not for a second, but now we can.
Yeah, sorry, I have a headset where I'm never quite sure whether it's on or off. Thank you very much, Leigh. That was incredibly interesting and very insightful on what it's like when you get a big project like this and try and implement it. I just wanted to sort of give some kind of guidelines about your status. Everybody is on mute now, but I'm going to take everyone off, and that means that if you have a question, we can sort of have a bit of a question and answer session. But if you don't want to speak, I would ask you to turn your mic off because otherwise we get the echo that we can hear now. So if you could turn it off unless you've got a question. So are there questions from the floor? Dania, did you want to ask a question?
Yeah, I did. Hi, how are you?
Hi, Daniel.
Can you hear me? Yeah, good. Hi, Leigh. I was wondering, with the incidental findings, well, actually, I would say secondary findings, if they're actively being sought for, how is that list determined? Is that based on the ACMG recommendations? And if so, is it being updated with the 2016 ones that they've put forward, or have you guys developed your own based on evidence that's in the literature?
Okay, so that list has been devised by Genomics England and their advisors, and I'd be keen to point out that it's not us guys here. I'm nothing to do with Genomics England. I think I can't stress that enough times actually. But it is, I believe, loosely based on the ACMG list. It's nowhere near as extensive as the ACMG list. It's kind of, I think they use that as a starting point, and then they had their own scientific committee evaluate all of those different genes to see what they thought were the strongest ones, because it's a controversial list to say the least. It will be updated. I believe it's quite a small number at the moment. I think it's only about 12 genes at the moment. But the consent is that they are consenting to whatever that list is at the time they get the results back. So it's not fixed at the time of consent. So that obviously is quite a tricky concept to get across to someone, that you're consenting to a list of findings. This is what they look like now, but it's not necessarily what it will look like by the time you get your results back. I believe the intention.
But do you actually give them the list, like when you show them the consent form?
Yeah, the list is available. Yeah, the list is available. It's highly penetrant cancer conditions and cardiovascular conditions, and that list is available and is updated on the website whenever anything happens to it. I believe the intention is for that not to happen very often, and that's why they kind of, I think, well, it's a much shorter list than the ACG one, because I think they held a higher bar of evidence to what they were happy to include. But yeah, it is a flexible list that may well change in time.
Okay, thanks.
I know Dr. Mark Taylor had a question.
Thank you. Thanks, Leigh. That was really interesting. Can I ask you to say a little bit more about the approach that's taken where consent to involvement in the project isn't taken prior to the surgery, but a consent to tissue bank, local tissue bank is taken prior, and then the project-specific consent is taken afterwards. Can you say a little bit more about how those consents differ and why they differ in ways that make it preferable to do it the way that you're doing it than the way that it was originally expected to be done?
Yeah, no problem. So I would say that is still in the minority of cases, and it's for issues when the patient has a real preference that they don't feel they can kind of think about things in the detail they need to. The difference being that it's an existing biobank locally that patients would be consented to routinely for cancer surgery anyway. So it's something that's already happening. So it's not an additional process, but also because it's a routine kind of, and has been in the NHS for a while, it's a far shorter consent process. It's a far shorter consent conversation. It's a very broad consent, and I think the idea is that can be used to make sure that the samples are there, and then the patient can decide in their own time whether they would like to be part of this particular project. So, you know, the way that the biobanking usually works is that the biobanking consent is enough for any of the projects that the biobank is authorized for, but it's been specifically excluded that this project is one of them. So it's not a way to bypass the kind of the consent for the project, more kind of push it back to a less time pressured situation, rather than you know, on some of these cases, this is the morning of the surgery for these people, and actually having a 45-minute conversation about the 100,000 Genomes Project and additional findings and carrier status and things like that, you know, it's certainly the feeling with our recruiters that that is the wrong time for these patients to be really considering all of those issues, and some of them find it a lot more helpful to do this kind of on reflection during their recuperation time.
Thank you. It's just interesting for me to reflect on why that should be the case. I absolutely understand, I think, that if this is a consent which is routinely taken anyway in the area, then it's the 100,000 Genome Project consent which is seen to be the additional one.
Yeah.
So this is something that's happening anyway. So why not use something that's happening anyway? That I get. What I think I don't yet properly understand is why the consent to a broad tissue, why a broad consent would necessarily be or would be shorter. The process of obtaining a consent to a tissue bank would be shorter and simpler and easier to administer than consent to a specific project. Now, you say that the consent process to tissue bank was developed a little while ago, and I think you indicated that might have something to do with it. So do you think that with regards to the 100,000 genome consent process, it goes into too much detail? Do you think it's unnecessarily long and complex? It just seems odd. You can see what I'm getting at.
Yeah, no, absolutely. I see your point.
It's really quick and relatively easy to get consent to a tissue bank where there may be all manner of uses subsequently made of it, and relatively more difficult and time-consuming to get consent to a specific project where there's much more tightly constrained uses.
Yeah, no, I think that's a really valid point, actually. What I would say on that, and this is kind of, again, this is purely in my experience, but you know, I've heard some of the clinicians talking to each other about the 100,000 genomes consent, and some of the recruiters and some of the patients, and you know, kind of uniformly, they do feel that it's a bit over-involved and it's a bit overly complicated, and it could be simplified, and it doesn't need to be as many pages and all the rest of it, and that is fed back. And also, I think there is a feeling amongst the clinicians that once the project part of this finishes and it gets kind of mainstreamed, that will all fall off, and it will become a very much shortened and simpler process. You know, I'm not sure that's what should happen, but I think there's this feeling that it's not sustainable in the NHS to have 45-minute consent conversations about anything. And so I think they are anticipating it's going to go, and I think that's where I say about the age thing. I think that's what's kind of, I guess, happened with the tissue banking thing, is that it's come down into routinization a little bit there. It's not a genetic tissue bank. I should make a point. It's a very different kind of animal. It's a cancer tissue bank. But yeah, I think that's the consequence, and I think that's what the clinicians probably expect to happen with this. And I think that's it.
Thank you.
Thank you. I know Natalia has a question for you. Is that still the case, Natalia?
Yeah, I'm sorry, I was having internet problems, so I missed about half your presentation, so you might have...
Oh, sorry.
Yeah.
We will download it onto our internet as soon as we can.
Okay, great. Well, I was wondering to what degree are details surrounding the incidental findings discussed during the consent process?
So again, to pick up on what Dan was saying, you know, the additional findings are discussed, and they are this list of additional findings that are sought for actively are discussed. And kind of the point that I was trying to make is that incidental findings are not really discussed during the consent procedure, because it is only findings in this list of genes that will be fed back. And so anything else that isn't there or to do with the reason that the patient was referred to the project will not be fed back. And so the additional findings part of the project is discussed at length during the consent conversation. But incidental findings in the truest sense of the word, I think it's fair to say, are probably not covered that well because they're not going to be fed back.
Yeah, I meant the additional findings.
Yeah. Yeah, the additional
So
findings are discussed. They get the list, and they get a kind of a background about why it's felt that that might be useful information, and they can opt in or opt out to that, and they can change their mind on that going forward as well. They can come back and say, actually, I've changed my mind. I don't want that information, or vice versa. So that is an ongoing kind of updatable preference that they can have.
Thank you. I haven't had notifications of anybody else with a question.
No more hands up.
Danya, hold on. Danya is back in the game.
Sorry. I have lots of questions, Leigh. I'm sorry. I actually just wanted to ask one that was just in relation to what you just said about them being able to come back and and reassess their consent options. Yeah. Does that happen?
It hasn't yet, as far as I'm aware. No, it hasn't. I'm not aware that has happened at all yet.
Because I think that is I can't remember who wrote a paper. I heard something about this. Maybe something that Sharon Terry was saying at a talk I heard. But it's ringing bells that apparently people don't, but they like to have the option to do that.
I think Jane has found this as well, haven't you, Jane, in Dynamics, that people like having the option and feel that that's a good thing, but don't necessarily do anything about it.
Well, only if they think that it's an important thing to do. Yeah. And Sharon talks about my sister's bike and saying that my sister's bike's there, and yes, I could just go and take it, but that probably wouldn't be the best thing to do, and that her sister would like to be asked. And that's the same with the use of information. So, and that's something that came out of some research that was done in Texas with, sorry, I've just forgotten her name. So yeah, I think that is really, really important.
Am I allowed to ask another question while I'm here?
Of course you are, Danya.
Well, just checking no one else has put their hand up since.
No more hands up.
Okay. So I wanted to ask about variants of uncertain significance. Yeah. And I'm assuming that they're not routinely reported.
No.
But I was wondering whether there was a policy about reassessment of VUSs and return of those findings if they eventuate to clinicians, and who might be able to initiate requests for reanalysis and that kind of thing.
Okay, so I'm almost certainly not the best person to answer on this, but as I understand it, that is going to be the role of the GSIP. So these are the Genomics England Clinical Interpretation Partnerships. So the kind of the variants that are certain and are disease causing and relate to the phenotype in that patient will get fed back, obviously. The ones that are definitely not will kind of just be left somewhere, and the VUSs will go to the interpretation partnerships for that reason, for further research, maybe functional studies, maybe reanalysis further down the line or after further publications. So I think that's the role of kind of researchers accessing the data, is for that very purpose. And I'm sure that then the expectation is, if it ever gets to a stage where that evidence is sufficiently strong to turn it into a class 4 or 5, a kind of likely or definitely pathogenic variant, then that would get fed back to the patients. Yes.
Great. So
again, that's how I understand it. I would hate to be absolutely quoted on that if that's not exactly the thing, but that's how I understand it.
Don't worry, I wasn't recording you.
No, well, someone else
you
is.
So are there other people who've got questions? Teresa, for instance, or there's actually 10 people online, which is good. So not everybody's got their camera on, but there are a lot of people online. any other questions? I'm not sure everybody knows how to put their hand up. How do you do that?
Shall I just quickly unmute everybody, and then
Yeah,
if anyone...
I thought I had done that. Well,
there we go.
people had muted themselves, I think.
Oh yeah, that's fine. If you want to mute yourself, that's fine. There's no question.
Yeah. So Leigh, I had a question for you.
Okay.
So you've done this work now, and obviously, I mean, what was really interesting for me to see is how kind of problems have been identified. So really kind of proactive mechanisms have been brought in, like so genomics champions, you know, kind of really sort of thinking about the way to really try and roll this out as kind of just standard practice. And I was just wondering, do you see that there's other issues coming up that will need some kind of remedy like that as well?
Yeah, absolutely. I think this is going to be a very kind of evolving process, actually, because you know, certainly in the Southwest at the moment, we've had, like, as I said, 870 odd patients and another 100 from cancer. I think we've had maybe 2 or 3 results back, and so I think when results start flowing through, then it's going to kind of really test all the aspects of the system and how it's working, and whether the information people get back kind of tallies with what they were expecting. And, you know, I think if and when the first additional findings come back, and then how that gets dealt with in the downstream testing that might need to go along with that. So I think there are going to be different issues coming up as we go forward. I think the single biggest issue is still, well, I think there's 2. Obviously, I was education and training lead, so I can't really not say anything about education. I think healthcare professional education in genomics is miles away from where it needs to be for this to become embedded in the NHS routinely. You know, I've kind of come from poacher turned gamekeeper here. You know, I'm now working at the university. My job last year was to recruit people to the master's course, and now they called my bluff and I've got to teach it. And I'm taking modules on it, so like I really do believe it's a good course. But you know, when the funding runs out from HEE, obviously the uptake from clinicians at the moment it's free. When that runs out, obviously that will inevitably drop off. And it's of such importance that we keep pushing this education and get down into medical student education and kind of build it from the bottom up, because you know, this is going to go outside of clinical genetics. It's going to be out into the specialties, and therefore we need at every level, at the nurse specialty level, at the consultant level, pathology, everyone needs to buy into this if it's going to work. So I think education is a real huge point. And the second point I think is this kind of this question of identity about what this is. You know, that still really needs to be drilled down on, because I don't think the patients and the clinicians necessarily are on the same wavelength as to what they think this project is, and I think we need to sort that out. And that goes back to the kind of the trust aspects that Mike was talking about. It's extremely important that this is both a trustworthy project and also a project that appears to be trustworthy. And you know, given that at the moment there's huge lengths of time between consenting and sample giving and getting the results back, you know, lots of people might not have very much recollection of what went on during that consent process. So when the results start flowing in, I think that's when we'll start having to be reactive to more issues that crop up. And then obviously there will be implications for the family members of those people that have consented that they may not have discussed. So yeah, I think it is going to be yeah, different challenges as the course of the program goes on. I think it's probably fair to say.
So, I mean, one of the things that you pointed to was actually getting results back. And so you recruited, what, 800 people, and you've had, what, 2 results back?
A handful, two or three, yeah. 2
or 3. So, I mean, it's a bit hard to recruit people. It's a bit hard to get clinical staff on board when they're you know, like they're really under pressure now. Yep. If you can't say, well, actually, we've got all of these results. I mean,
absolutely, theoretical results aren't nearly as enticing as actual real life patients with stories. And there have been a couple of very good stories nationally with diagnoses being made and treatments being given, and actually big success stories. But our comms team locally have got kind of BBC on speed dial, waiting for that moment that the first result comes in that actually has a diagnosis, and then we can sell that to the clinicians. Because at the moment, it's still, this is why they think it's a research project, because a clinical test doesn't take 14, 18 months to get you an answer. And it's different again on the cancer arm of the project, because their patients may well never get a clinically relevant answer that's going to affect their treatment. For the rare disease, the current estimates of 25 to 30% is a fantastic result for a genetic diagnostic test, given that these people have been through all the other genetic testing processes before that. So, it's something that really needs to be pushed, that we need to give access to this to all the patients that could benefit from this, because that's a hugely powerful test that at the moment is free and won't be for very long. But as you say, that's a lot easier to do if you've got 500 success stories sat in front of you.
Are there any other questions out there?
Can I just come back in, Jane, and ask another? And it relates to something you just said, Leigh, but also something you said earlier. When we're thinking about genomic information literacy, and you're saying that we're still a long way away from where we ideally would want to be with regards to clinicians, do you think that's also true of research ethics committees and the conversations you've had with research ethics committees? Has that been apparent to you?
100%.
But a follow-up question to that relates to the point you made earlier about research ethics committees' view being that researchers should not pursue discovering, identifying any incidental findings, and it just occurred to me whether that was because they were viewing incidental findings in a particular way, and whether their views would be different if they were additional findings or secondary findings, or I wonder if you could say anything more about why you found that, if you know and have any ideas about why you found that view expressed within the research ethics community.
Okay, so for the first part of the question, yes, absolutely. I think genetic literacy on NHS research ethics committees is a serious issue, and it's one actually that the participants flagged up themselves during my study. Actually, that at best there was one person on the committee that knew anything significant about genetics, and they would be the person that gets sent for genetic research projects. So you suddenly reduced your committee to one. And in some of the other circumstances, they had nobody, so they would ask someone at the local university or the local hospital for advice whenever they got a genetics research project in. So then suddenly it's reduced to one, and that person isn't even part of the committee. So I think there is a good argument for specialized research ethics committees with extra training in genetics and extra genetic literacy to assess these kinds of projects because of the complexity involved. Where they were talking about not going on these kind of fishing expeditions, as quite a few of them termed them, I think that was a function of the fact that it was a research setting that we were talking about specifically there. So this wasn't 100,000 genome analog. This was 100% research, and they felt that it should be very strictly kept to the research question. And they felt uncomfortable with going outside just because you could and having a look at what else you could find, because then you'd have to deal with all the fallout from that. I actually think that in a clinical setting, the same people might be more happy with that approach, because the follow-up question was about the overruling of participants' consent, and that was a bit of my study that completely shocked me, that actually a vast majority were happy to overrule a participant's consent if it had health implications for them or even their families, and not even for them. And so this was in a case where you had discussed the possibility of incidental findings before the study. You were happy that they'd understood it, and they told you they didn't want to know. A large number of these people still wanted to tell them anyway. And the reasons given for that were that it was an onerous burden on the clinician to have this information, not be able to do anything about it. And certainly if they were a member of the healthcare professions, that they've got a duty of care and all of these things that we kind of know about, the kind of the research clinic kind of overlap. And so I think the flip side would occur when it's in a clinical setting, that they'd be more happy to look outside as long as it's things that they would feel that they would want to tell people anyway. And I'm sure that's where the motivation has come for these lists. I mean, it's not something I necessarily agree with, but I'm sure that that's where it's come from, to kind of alleviate the potential for this discomfort in healthcare professionals having information about their patients where they could be, or even their patients' families, and not being able to do anything about it. I'm not sure if that's necessarily answered your question. But...
It has. I mean, if I can just briefly follow up, would it be your view that in those circumstances, rather than asking people whether they want these additional findings, if they can be anticipated and if their clinical relevance is foreseen in advance, it's more difficult when they're genuinely incidental, but for those things which you can anticipate finding and being relevant clinically to them or their family, then if we're going to find ourselves in a situation where a research ethics committee think that they should be fed back because of the duties that the clinicians owe, then we shouldn't be asking these individuals whether or not they are agreeing or not. We should just be telling them that this is something that would happen if they agreed to participate in the program.
Yeah, I mean, and that's certainly the route the American College have gotten down, where it was not given as an option. These were the list of genes, and you will get these if you have any kind of sequencing. And
They had to roll back on that, didn't they?
They subsequently rode back on it, after the kind of the backlash against it. And I think that backlash has been informative to the decision making in Europe on these sorts of things, and not taking that approach of insisting upon things. I think if you ask for my view, it would be that, as I said, I'm less than convinced that these incidental findings are things that are certain, and I don't think we know enough about them at the moment. And I think we are too early in the game to be feeding these sorts of information back to people until we are very certain that in a population context with no family history, that they have the same kind of risk factors. So I think I'd probably go the other way and say that actually you're being recruited for this condition. That's all we're going to look at. I spent my day this morning filtering variants in bioinformatics pipelines. It's absolutely possible to not look at certain things and to only look at the things that you want to look at. So why don't we do that? And also then you get into, this then becomes a kind of proxy population opportunistic screen, and, then certain people are not getting access to this, and it's the only people that already have an existing genetic condition that suddenly get access to screening for lots of other genetic conditions. And we can have all sorts of discussions about how fair and equitable that is. So yeah, I think it's probably coming across that I'm not a massive fan of routinely feeding back incidental findings. But however, I mean, and what I will say, and there's a huge caveat to this, as part of the project, the patients do have the right to their raw data. And so whatever decisions get made for them about what gets fed back, they can just walk away with their variant file and go have a look themselves, or get someone else to have a look for them. So, to an extent, it's all a bit of a moot discussion because it's all in there anyway. But yeah, I think there's probably still quite a lot of debate about, which is why I think it's interesting to see how this pans out when they come back. Because there's probably only going to be a handful, like 50 to 100, maybe, for the project that actually get some kind of additional finding back, and seeing how that's dealt with will be interesting. I mean, there are studies in the US showing that there's no difference in kind of psychological well-being after getting incidental findings, but that, again, that's all predicated on the basis they were true. And if they're not, then I think that's a bigger concern.
Thank you.
Great. So I think we're nearly coming up for time, aren't we?
Yep.
So I just wanted to thank Leigh for taking time to give this presentation. It's been really fascinating to get such an insider's view from a scientist, but also a social scientist, and also someone who's been involved in the implementation of this project. But also you gave us such a clear insight into some of the challenges of doing this, but also some of the potential of it, but also some of the challenges that lie ahead. And so it really, it makes me realize that Genomics England is such an infrastructure platform, really, and that the real benefits of it may not be realized for another 5 to 10 years, but how much effort has gone into actually really changing practice and developing a new way of doing things. So thank you so much for the insights into that. Just like to, yeah, thank you. I'd just like to say that we have got, as part of this series, we've got Sandy Dienser coming, and sorry, I'm looking at a poster on the board on Wednesday the 18th of April, and then Annika Lucassen on Wednesday the 23rd of May. In May, we also have a personalised medicine series that has been led by Barbara Prainsack starting, and Imogen will send out details of that close to the time, though I think she has already. And also we have a series starting on community engagement that is being run by our Japanese college, Go Josigal Sawa, and a colleague of his from Indonesia, and that will start on the 23rd of May. I also know that another series is being planned on data sharing, and so when the dates come in on that, we will let you know. Thank you to everybody who's made this. We realize that we're always constrained by time zones, and that this probably hasn't been a good time for our colleagues in other parts of the world, but we're delighted that everyone's made it, and thanks once again, Leigh, for your presentation, and also thank you, Imogen, for all of your
thank you, Imogen, for help setting up, and thanks for the invitation, Jane.
Okay, great. Thank you very much.